Hi, I'm Dr. Zab Muzanafar, Professor of Medicine at UCLA School of Medicine.
Hello, my name is Dr. Sharaf Khaneh, a pulmonologist from Baylor College of Medicine, and I'm hoping that this data will be helpful in your clinical practice and also in your patient. The first question, which I think is very, very important to address, is what is the impact of COPD on your patients? COPD is underdiagnosed in the United States. And what do we mean with that, underdiagnosed? Currently, from the databases that we have, we know slightly under 13 million Americans, or being exact, 12.7, are affected with COPD. But also the data from CDC clearly indicates that up to 24 million adults in U.S. suffer from this disease.
Majority of these patients are under 65 years old. As a matter of fact, 70% of patients with COPD are under 65 years old. What this slide shows, the hospitalization account for roughly 50% of the costs associated with COPD. 51% of the cost of the inpatient hospitalizations, 27% indirect costs, 6% laboratory, ER visits about 5%, and primary care specialist visits roughly about 7% of the cost, and remaining 4% is the treatment cost.
How much is the yearly cost of COPD? This is close to $50 billion a year, that basically the cost, indirect and direct cost of that. And the direct cost is close to $29.5 billion. And this is a very important number for you to remember. What I want you to know is that the majority of the cost of COPD is hospitalization, and the cost is very, very big, especially in this day and age that we talk about the cost of healthcare. Who basically suffers more in regard to the healthcare costs? People who are younger, and specifically younger than 65, have higher costs. COPD is a prevalent disease, and it's very, very costly, and it affects younger age despite the current understanding or current feeling that it is older disease. Let's talk about how COPD affects our activity level. Let's think about the physical activity and shortness of breath. What happens in the course of COPD? A regular COPD patient, a typical COPD patient, start having gradually shortness of breath. What they do with shortness of breath, they change their lifestyle. They will do less activities that they like, and they become more sedentary, because any activity that they do may produce shortness of breath and brings the limitation. In response to that changing to the sedentary lifestyle, the patient will have deconditioning that will put the patient in what we call it vicious cycle. That means deconditioning promotes more shortness of breath, therefore more sedentary lifestyle.
There are misperceptions and denials of both symptoms and activity limitations are significant barriers to diagnosis and management. Patients may misunderstand or minimize symptoms such as fatigue, dyspnea, or cough. They may neglect to mention that these symptoms really are primary symptoms, and they would not mention to their healthcare providers. Symptoms may be misattributed to asthma or getting older or getting tired or stress of job, and things that you might hear. I've been coughing when I wake up each morning, but it's really smoker's cough. This is normal, and it's not really harmful to my health. Or you may hear from them saying that carrying these groceries is harder than it used to be. I must be old or getting out of shape. Or I don't need my meds for my breathing because it's not really a serious problem. So these are a series of things that you might hear from patients, and indeed they really deny their actual symptoms.
Let's go back again to the same concept of basically shortness of breath and changing our lifestyle. Why are patients with COPD are short of breath? The main mechanism that results in activity limitation and shortness of breath is a term called expiratory flow limitation. Make it very simple. Your patients are not able to breathe out normally. Then not being able to breathe out normally results in what we call it air trapping and hyperinflation. Now, hyperinflation results in shortness of breath. And obviously, if we are short of breath, we will do less activity. And by doing less activity, we will fall into this vicious cycle, which results in more deconditioning and therefore more shortness of breath. And of course, it will affect the quality of life, and we will see disability, disease progression, and death. one of the components of the disease, which is COPD exacerbation, will enhance this vicious cycle and will cause our patient to go to that worse outcome, which is disease progression and death, faster.
As I mentioned before, airflow limitation leads to this cascade of events. But what causes bronchoconstriction in COPD? Generally, there are multiple factors.
In this cartoon, I'm showing you a very detailed reasoning for this symptom and this pathophysiology. I'm showing you a small airway. In the middle of this small airway is, of course, the lumen, and as you see, it is very, very narrowed. But you see also some green stuff there. Well, you can guess what are those green stuff. Those are what we call it sputum. And of course, this is a sputum in the small and medium-sized airway. And in many occasions, your patient are not able to cough up this sputum because it relies heavily on mucociliary function. And of course, mucociliary function is disturbed with the smoking and COPD. Now, the second change you see in this slide is the thickening of the airway wall and, of course, hypertrophy of smooth muscle. Therefore, we have two clear reasons that our small airway is constricted and therefore patient is not able to breathe out normally. It is like your patient is breathing through a very narrow straw. Now, there is a third reason, which is destruction of the alveolar wall. The alveolar wall attaches to the airway and pull the airway and hold the airway open during our breathing, but because it is disrupted at this point, it's not performing its function.
Airflow limitation leads to air trapping and hyperinflation. Hyperinflation results in low flattened diaphragms and airway trapping. Increased cholinergic tone contributes to airway narrowing and bronchoconstriction, which leads to air trapping. So combination of these factors, you have a hyper-aerated lung, and on the X-ray you see a lot of darkened and flattened diaphragms.
Let's make ourselves familiar with a concept called room to breathe. We have some abbreviations that I would like to tell you a little bit about. One is called TLC. TLC is the maximum amount of air that you can put in your lungs. And as you see, there is another abbreviation called residual volume, or RV. And that will be the minimum amount of air that, as long as you're alive, will stay in your lung. So you cannot get rid of RV. It's going to be always there. What you can do is basically called vital capacity, which is the difference between TLC and RV. Now, let's look at the time that you are breathing in and out normally. If you basically take a deep breath to your maximum lung volume, the amount of air that you can take inside your lung, starting from end of your expiration, normal expiration, to the top of your lung is called inspiratory capacity. Now, the IC is an important issue. The IC is the amount of air that you can breathe in and out. Therefore, it's the amount of activity that you can do. Now, what happens with hyperinflation? Let's move to the situation that the patient has hyperinflation. If you remember, IC was significantly large, and in this situation that we are seeing in blue, the IC has reduced. Therefore, the amount of room to breathe or amount of activity that our patient can do is significantly reduced. Room to breathe is the amount of air that you can move in and out. If I can improve your room to breathe, you can do better. If I reduce it, you will do less. And that's an important factor when we look at the pharmacotherapy. Now, let's look at the more discussion about the inspiratory capacity and how it can affect our patient's activity and life.
Patients with COPD have significant limitations. This is normal physical exertion. They're limited. In terms of the lifestyle, they're limited. In terms of household chores, in terms of social activities, and sleeping. So that through the broad spectrum of the lifestyles, COPD patients, they have significant limitations.
Also, we would like to look at basically the age of the patients, how it is affected by various chronic conditions. And in this, basically, we are lining COPD compared to other chronic condition, compared to the disease that you have heard a lot, asthma, and compared to an individual who does not have any chronic problems. And what we are trying to find out is that if this is affecting the patient's ability to basically work, and it's how it's affecting. And the bottom line in this slide is a larger number of the patients with COPD basically a smaller number of the patients with COPD are able to function properly compared to the other chronic condition and compared to an individual who does not have any chronic medical problem. How does COPD may impact work-related activities? And we are specifically focusing on the various severity of COPD. Let me just give you a small explanation about a GOLD and what is the GOLD classification. Of course, this comes from Global Initiative for Obstructive Lung Disease. And as you may guess, GOLD stage 2 is much milder than stage 3 and 4. And as clearly shown here, we are looking at the different conditions in patients with the various severity of COPD. Let's look at the work time reduction. And as you see, 65% of the individuals who have severe or very severe COPD, which is GOLD stage 3 and 4, shown in dark blue, have basically somehow reduced work compared to the milder form of disease. And this is, you see the similar basically findings that with other issues, for example, quit doing some task, difficulty on doing their job. As the COPD severity gets worse, your patients have problem with performing at their work.
Employees with COPD incurred 4 times higher total mean healthcare costs compared to their counterparts. Look at this slide. It controls $3,634 versus $15,875.
So the cost of COPD in the work environment is almost 4 times per individual who are affected with COPD. And again, as you see, a large part of that cost relates to inpatient and outpatient costs.
Airflow and physical activity levels begin to slow down at early stages of the COPD. Even the mild COPD, the stage 1 GOLD, have fairly small and very mild reduction. Their FEV1 has an impact on their decline early stages of the COPD.
COPD affects the physical activity, affects the work performance, and as the COPD severity increases or gets worse, the amount of activity the patient is doing is reduced significantly. This is a very, very interesting slide that looking at COPD patient compared to healthy control and more or less matched for their age, and they are looking at 4 different kinds of activity: walking, standing, sitting, and laying down. It is very, very clear from this slide that individuals that are healthy control are doing activities that needs more ventilation. Basically, the activities that are more active, like walking and standing. In contrast, your COPD patient spend more time on activities that are more passive and requires less ventilation, like sitting and laying down. And this is one of the important issues that we need to consider. Our patients, as they become short of breath, they change their lifestyle. They change the activities that they do, and they become more passive because they're short of breath. And this is the beginning of the vicious cycle that we need to, as practitioners, to prevent.
Undiagnosed patients experience symptoms that impair their ability to perform activities of daily life. This is the data showing that patients with needing help with personal care compared to difficulty with walking, and COPD patients have significant limitations with activities of daily life.
That is very, very important, that some of our patients with more severe form of the disease that may not be able even to take a shower, they may not be able to do activity of daily living, they may not be able to cook or go for shopping, and they are severely impaired. Let's look at the correlation between pulmonary function test and exercise capacity. Because what I'm trying to do here, I'm trying to show how hyperinflation and airflow limitation, which is shown by FEV1 reduction, correlate and how it pushes our patients to a vicious cycle. We are comparing 50 COPDers with 25 normal control. The severity of COPD here is shown by FEV1, which is 43%, in contrast to healthy individual, which is around 111%, which is within normal limit. Now look at if we measure their muscle function. The quadriceps force is significantly reduced. It's 56% of normal. And of course, we use significantly quadriceps for walking. And that very well goes with the type of activity reduction that I showed you in prior slides. Now look at the exercise capacity. Now we are not just looking at the muscle, we are looking at the whole patient performance. Now the percent of normal of walking, that means you ask the patient to walk for 6 minutes and you find out how fast they can walk and how far they can walk. Only 62% of normal, while healthy is doing 98% of what is expected, which is very good. And when you put them on a bike and ask them to exercise, only 49% of normal. And when you look at how much oxygen their body picks up during the maximum exercise, only 55%. So all of these fits in line with one concept. Expiratory flow limitation results in hyperinflation with reduction of inspiratory capacity, reduction in room to breathe, and therefore our patients are not able to do more. What they do, they change their lifestyle and they do less.
This slide shows increased severity of COPD affects activity levels, lung function, and frequency of symptoms at all stages of the GOLD stages.
We have again stage 1, 2, 3, and 4, and as you know, as the numbers go up, the severity of the illness is more. And as you see, FEV1 is of course significantly lower, and the number of the steps that patient can take significantly go down. And not only that, as FEV1 goes up and the number of the steps goes down, patient have more symptoms, frequent COPD exacerbation, and of course at the end they will have respiratory failure, which is clearly results in death. One important fact is your patients will change their lifestyle and they will not come to you, tell you that they are short of breath. So as a practitioner, you need to actively be engaged in asking the patients questions. And these questions can be different type of question. You want to know if their leisurely activity has changed. You want to know if their hobbies has changed. You want to know if few years ago, 3 to 5 years ago, they were able to do something that they are not able to do more now. And you need to document this because when you start the therapy, you want to see if the patient is going back and improving in that regard.
Exacerbation also impact activity levels. Exacerbation in terms of the frequency and severity of exacerbation increase throughout the disease course. And as the exacerbations get more frequent, you have expiratory limitation, air trapping, hyperinflation, dyspnea, the vicious cycle of reduction in exercise endurance, and the condition combined creates more activity limitation and decrease in quality of life. GOLD guidelines definition of a COPD exacerbation is that there's an acute event in the natural course of the disease beyond normal day-to-day variations. And it's characterized normally by a change in the patient's baseline dyspnea, cough, and or sputum production, and may warrant a change in the regular medications.
And COPD exacerbation may be caused by bacterial infection, viral infection. It may be because there is pollution in the environment, and in many occasions, up to 1/3 of exacerbation, we may not be able even to find the cause. But it's very important to recognize what is COPD exacerbation. Let's look at COPD exacerbation and effect of COPD exacerbation on the quality of life, on the lung function, and the cost of COPD exacerbation. There are many studies that shown clearly that people who exacerbate more versus the individuals who will not exacerbate more, they will have more lung function decline. That means the FEV1 goes down faster in individuals who basically have more COPD exacerbation. Also, the quality of life is affected with COPD exacerbation, and this is not difficult to understand because if you're very short of breath, you can't do anything, and you have all this phlegm and cough, you can't sleep, your quality of life is going to be worse. But you remember that I told you 51% of cost of COPD relates to hospitalization. And guess what? Hospitalizations are due to COPD exacerbation. So COPD exacerbation is very costly. It affects the lung function, it affects the quality of life, and it's very costly. And also, therefore, from the physician standpoint, we need to teach our patient about that. We need to recognize and try to prevent COPD exacerbation.
Exacerbations have an impact on activities of daily life. If you look at this slide, impact on ADL during exacerbation versus at all activity levels, need additional help with certain tasks or just the routine activities. Clearly, during the exacerbation period, these activities get impacted.
86% of individuals who were surveyed basically clearly indicated that they are not able to do regular stuff that they do for their living during exacerbation. Not only that, 47% of this individual also said that they need to stop all their activities during the exacerbation.
How can management goals help improve the lives of patients with COPD? Comprehensive approach with COPD management, the treatment goals are relief of symptoms, prevent disease progression, improve exercise tolerance, improve health status, prevent and treat complications, prevent and treat exacerbations, and obviously reduce mortality.
You want to stop patients dying from COPD. Now, there are many approaches available. One of them, of course, which is universal and needs to be done, is a smoking cessation. But of course, on top of smoking cessation, we have many interventions that can achieve many of those goals that includes medication and, of course, non-pharmacological intervention. We're going to talk about impact of impaired lung function on patients with COPD. It is very, very important to remember that patients, as their disease progresses, spend less time on their physical activity, and specifically physical activities that are more active, like walking and standing. And they will spend more time on activities that basically is sitting and laying down, that does not need that much energy, or that does not need that much ventilation.
They have difficulty doing their job. They change their family habits and leisure activities. They decrease their ability to do household chores, and they have difficulty getting washed or dressed.
When you think about the treatment of COPD, it's very important to basically think globally and not just think about the pharmacotherapy. The important thing is smoking cessation. We need to help our patient to think about smoking cessation. It's very addictive. We need to help them. We also need to think about pharmacotherapy. And added to that, you need to include them in pulmonary rehab that will help them to be more active.
Smoking cessation can slow COPD onset and progression. If you look at this curve, this is the Fletcher curve and Fletcher-Peto curve, and it shows that if exposure to noxious gases, i.e. Smoke, stops, disease progressions slow down. If an individual has never smoked, our lungs are designed to last perhaps 80, 90 to 100 years. Smokers, in contrast, as you see, by the age roughly 71, 72, they have lost significant amount of lung function, which is not compatible with life. If they stop smoking at age, let's say, age 45, you can see that the progression of the decline gets halted. In other words, the decline that they were subjected initially changes the slope. In other words, by age 75, they still have significant amount of lung function left. Even if they stop at age 65, that has an impact. So smoking cessation is a very, very important step in managing COPD. Benefits of pulmonary rehabilitation in patients with COPD are numerous. Rehab programs improve exercise capacity, reduce the perceived intensity of breathlessness, improves health-related quality of life, reduces the number of hospitalization and days in the hospital, reduces anxiety and depression associated with COPD. There's a significant improvement in strength and endurance training of upper and lower extremities in rehab programs. And the benefit extends well beyond the immediate period of training. It has been shown that it does improve survival. Respiratory muscle training is beneficial, especially when combined with general exercise training. And obviously, psychosocial interventions is very, very helpful.
Let's look at the treatment and pharmacotherapy of COPD. And again, as you see here, we are going with the GOLD guideline or Global Initiative for Obstructive Lung Disease, and we are looking at different severity of COPD. We have mild, moderate, severe, and very severe.
Stage 1 disease can be managed by short-acting bronchodilators as needed.
Now, if the patient has moderate disease, that means their FEV1 is less than 80%, but more than 50%, you still will give them short-acting bronchodilator. But all the guidelines universally emphasize that we should consider using long-acting bronchodilator will provide persistent coverage during the 24-hour.
Stage 3, that's when the inhaled steroids become into play, plus long-acting bronchodilators and short-acting bronchodilators as needed. Very severe disease, very severe patients that they're stage 4 gold, they require oxygen, they require inhaled steroids, at times oral steroids or intravenous steroids, plus long-acting bronchodilators and short-acting bronchodilators as needed. COPD is a preventable and treatable disease. Take a minute to screen patients for COPD. Enhance patient-physician communication. Use handheld devices and screening tools. Confirm diagnosis with spirometry. Use multimodal treatment strategies such as smoking cessation, pharmacotherapy, and pulmonary rehabilitation.
The sooner you capture your patient, the more effective you are in saving their lives. You will prevent disease progression earlier, so screen your patient. Don't wait for your patient to come and tell you that they're short of breath, because when they tell you they're short of breath, they have lost almost 50% of their lung function. Now, talk with every smoker, especially if they're 40, 45 and higher. See if they have symptom or not. See if they have changed their lifestyle. Let me thank you for watching this program, and I sincerely hope that the data that I presented here will become handy in the diagnosis and management of your patients with COPD.